Hello, everyone. My name is Molly Bachmann. I am a pelvic floor physical therapist at Pelvic Health and Rehabilitation Center at our San Francisco office. My pronouns are she, her, hers, and I am so excited to be presenting to you all today. I'm going to go ahead and share my screen. And I hope that everyone is able to see clearly. Let me find presenter mode here. There we go. All right. So as I mentioned, my name is Molly Bachmann, and I am presenting to both physical therapists and patients today. So I'll be using some medical terminology, but we'll try to break it down so that everybody is able to understand clearly. I am going to be speaking about the intersection of physical therapy and pregnant people and how we can use our skills to benefit and help prepare pregnant people for this exciting time in their lives. So my hopes today is that everyone will have a kind of basic understanding of the anatomical and physiologic changes that a pregnant body is going through. I hope that you understand the intersection of pregnancy and physical therapy and how these two worlds merge and combine and how we can actually help each other. I hope that you identify key factors and areas of creating safety in pregnancy. I hope that you feel confident in advocating for your physical needs during pregnancy, and that we identify some key areas to support preparation for the intrapartum experience. And intrapartum is a fancy way of saying labor and birth. So this is a presentation that really could be done over a series of weeks. So I tried to condense it down into one comprehensive lecture, but I know there will be questions following this, and that is absolutely okay. Hopefully through the use of our platform and working with your physical therapist, those questions can be answered appropriately. But we likely will be making even more presentations. So again, hopefully all of your questions can be answered. We will also be talking about the postpartum experience and physical therapy in the future as well. So first, I'd like to briefly talk about some of the anatomical and physiologic changes that a pregnant person goes through. And I could talk about every single system in the body, but I really, again, for the sake of this presentation, narrowed it down to ones that we as physical therapists are primarily either concerned about or thinking about as we create a physical therapy program for our patients. So the first big change that a person is going to go through is hormones, and we throw this word around a lot, and we have multiple hormones that change throughout pregnancy. And so the first big one that we often talk about is oxytocin. This is kind of the feel-good hormone. This is the hormone that gets predominantly released the moment that baby comes to your chest, and it's instant love, and you feel that deep connection with the child. And there's a physiologic reason for that. So this is a hormone that is released from the pituitary gland, which if you point to your nose and the top of your head, where those lines merge, that is where your pituitary gland is. One of the things that this hormone does is that it stimulates uterine contractions and lactation. So for example, if you were to manually stimulate the nipples, manually meaning with your hands, this can actually help to stimulate uterine contractions during birth. It's also a really wonderful way to connect with your partner. Um, this hormone enhances your mood and infant bonding. As I mentioned earlier, everybody knows the moment, that first moment when the baby comes to the chest and you feel that instant bond. That's oxytocin doing its job. Um, Oxytocin is also a really wonderful hormone that helps to reduce the risk of postpartum depression, which is not often talked about, and physical therapists are capable and should be screening for this as our pregnant people and postpartum patients come in. But this is a hormone that we want, and we want a lot of to be circulating around our body. The second hormone I'd like to talk about is relaxin. Now, most people, when we talk about relaxin, it basically does what its name suggests, is that it relaxes things. And in particular, we're talking about ligaments. And so, in the context of physical therapy, when we think about the pelvic girdle, for example, which is where your hips meet your spine, that's that whole circumference, that's your pelvic girdle. When we talk about relaxin, it's trying to target ligaments and get them to lengthen so that your pelvis can expand and allow the baby to descend into the pelvis through the vaginal canal and then out into the world. Um, Now, this is something that this hormone, it's not just present during labor and birth. It starts in the weeks and couple of months prior to that, again, as preparation. Um, the reason why I kind of hesitated at the beginning to even include this is because there is some controversy as to how much this hormone contributes to changes within the pelvic girdle. So historically, it has been referred to as the hormone that releases all that tension in the ligaments, stretches things out so the pelvis can expand, and therefore gets blamed for a lot of low back pain, um, and therefore can be dismissed in a doctor's office. So, for example, a patient may come into a doctor's office or to their birthing professional and say, "Oh, I have this low back pain." And the doctor often will say, "Oh, it's probably because of relaxin. It's just going to go away when you're not pregnant." Um, and what we're finding is that that's not always the case. And so what may be happening is, yes, maybe these ligaments are stretching and lengthening and allowing the pelvis to expand and open up. Um, but why do some people have low back pain and others don't? And that really comes down to what we think is the body's ability to generate enough strength and force from those muscles in the pelvic girdle to create a kind of closure in that SI joint. And there's a lot of nuance and context to this. Again, if you're working with a physical therapist, they can help you understand if this might be something that is happening with you. But I just like to give that caveat because it is more nuanced than just saying, oh, relaxin is responsible for all low back pain in pregnancy. And that's just not true. Um, Thirdly, let's talk about some hormones that influence the placenta. We have progesterone swirling around. We have HCG, which is I can't even pronounce some of these words, chorionic gonadotropin, human placental growth hormone, and estrogen. And so basically, I have these here to say, these are the ones that are responsible for developing the placenta and keeping the placenta healthy so that you can have a viable pregnancy and fetus. And then lastly, um, one of the reasons why it's important to understand hormones and hormonal regulation during pregnancy is because your body kind of creates this environment that can be, again, not always, but that can be ripe for autoimmunity to suddenly reveal itself. Um, and so, as physical therapists, and hopefully physicians and other birth workers are paying attention to this, um, asking questions like, have you noticed that suddenly you have a sensitivity to certain foods that you didn't used to have before? Or have you started to notice changes in the quality and texture of your skin? Or have you noticed that maybe your eyes are really dry? Or just things like that can be clues that um, maybe some autoimmunity may be developing. And again, there's a lot of nuance to this, but I just like to plug it in there as, make sure that we're thinking about this, screening for this, um, as we see patients, and for you all who are patients to pay attention to what your body is going through, because some of these things can be related to pregnancy. Um, when we talk about autoimmunity, um, because that inherently implies a new stressor on the system. This is kind of what we call allostatic load in the science medical field. It makes it challenging for our sex hormones, which are estrogen, testosterone, progesterone, um, to kind of return to that normal baseline and to allow for postpartum healing. Um, so, again, paying attention to these changes is really crucial. And you don't have to be hyper vigilant about it, but just make sure that your ears are tuned on or turned on, and you're kind of listening to your body as you go through this pregnancy. Um, one of the big um, autoimmune components, which we're starting to identify, is related to type 1 diabetes and sometimes type 2 diabetes as well. This is why your doctor will frequently have glucose checks. And that's something that's really important to pay attention to, because we want to make sure that even if you do develop some glucose um, related issues, whether it be gestational diabetes or whatnot, we want to make sure that you're able to heal sufficiently postpartum. So, again, having your ears turned on, being aware of these changes that are happening in your body can be really crucial. Cardiac changes. What happens to your heart during pregnancy? This is really fascinating to me. So, 10% of pregnant people will have high blood pressure. And that is not something to be messed with. This is why I, as a practitioner, always check blood pressure at every single visit for every single pregnant person, even if they have um, no history of cardiac issues. This is something that can change so rapidly, even within the same week. So, let's say at the beginning of the week, your patient is going to a doctor's visit or a visit with their birth worker, and they say, "Oh, my blood pressure is fine." I usually would say, "I'm so glad, but let's just check again. This is not something that we want to miss." Um, and it can be quite serious if your blood pressure is outside of what we consider to be within normal limits. I oftentimes will urge patients to also get a blood pressure cuff for home so that they can check it as well. Again, does not have to be something that you're hyper vigilant about unless you have a history of cardiac issues. But it's a really great indicator of what's going on in your body. It's a vital sign. It's how we know that you're surviving and thriving sufficiently. So, this is a really great way to check in with your body. As your abdomen expands outward, because the uterus is expanding and the baby's growing, your heart is displaced upward, forward, and to the left. Pretty fascinating. Um, Cardiac output changes, and we see a 40% increase in stroke volume. Plasma volume increases by 50%. So that's when we think of blood, most people think of the red blood cells, but plasma is kind of the watery fluid that those red blood cells and white blood cells are bathed in. Um, and we also see a 30% increase in red blood cells. And the reason why is because now that your body's responsible for your body and the body of another human, or maybe multiples if you're having multiples, um, those red blood cells are the ones that carry oxygen to all of our muscles and organs and everything. And so we have to have an increase in red blood cells because now we're responsible for two beings. And same thing with the plasma volume. We're responsible for two, so we gotta up the ante there. Heart rate will actually reach a 15% increase by the third trimester. So knowing your baseline pre-pregnancy and in the first and second trimester of your heart rate, which can be checked right here along the carotid artery or down here next to your thumb. Knowing your baseline can be really important because that's how you're able to tell, am I way too far away from my baseline or am I right on track? Even though we really press the importance of understanding your own blood pressure and being mindful of it not getting above that 130 range, really, your blood pressure should decrease and be at its lowest at 28 weeks and then actually rise again to pre-pregnancy levels at 36 weeks. That's an expected ebb and flow of blood pressure. Anything outside of that is something that we want to be communicating with your birth workers about and making sure that you're getting appropriate testing and care to resolve any potential issues. Respiratory changes. So the respiratory system is our lungs, our pulmonary system. So what happens to our diaphragm, you can kind of see me in the little video up in the corner here. Your diaphragm is kind of like a dome, right? And it moves up and down as we breathe. The diaphragm actually elevates up into the rib cage about 4 centimeters. Woo! Reason why? It's got to move out of the way for this growing uterus and growing baby. Because of that, because we have this ascent upwards and your lungs, the lobes are up here, right? Your lung capacity decreases by 4 to 5% just because there's not enough room and your diaphragm can't get as much of that normal excursion that it's used to. The vital capacity, however, does not decrease. And so vital capacity is the volume of air that can be expelled from your deepest breath. And the reason why is because we go from this diaphragmatic breathing to more of like an apical breathing or breathing from the rib cage. And that's something that can be trained if you feel you're not doing it sufficiently. Oxygen consumption increases by 10 to 20%. For obvious reasons. We gotta have oxygen to bind to those red blood cells to go to the baby to promote growth. And then tidal volume also increases, and that's the amount of air that moves in and out with each breath cycle. Pregnant bodies are amazing. I'm always blown away every time I reread these facts. The GI system, gastrointestinal system. So when we think about pregnancy-related issues, at least from a pelvic floor physical therapy perspective, and most of what I see clinically is that patients will come in and complain of constipation. And this is relatively common, though constipation is never really ideal or what we would consider normal. And the reason why constipation arises during pregnancy and sometimes can persist into the early postpartum and beyond is because we have decreases in intestinal motility. So that's the ability of the intestines to literally squeeze fecal matter and stool throughout the small intestines and colon into the rectum and then out the anus. And so why does this happen? Well, kind of two reasons. One, we have these changes in progesterone and estrogen levels. In our gut, we have progesterone and estrogen receptors. And so when we have changes, the GI system isn't getting the same kind of input that it's used to. Because that motility slows down, your bowels and body start to increase its water absorption, which is needed to get that plasma volume up, right? Going back to the cardiac system, everything's related, and get nutrients to the baby. But when we have that increase in water absorption from the GI tract, it increases the likelihood of constipation because now the stool becomes more dehydrated and that's tougher to move through the system. This is why hydration is so key during pregnancy. This is also why sometimes people require supplementation, either from fiber or colase or many other mechanisms, just to improve the motility of the stool through the GI tract. Additionally, when we talk about GI changes, many pregnant people will experience acid reflux. And this could be anywhere from 30% to 80% of pregnant people based on the research, which is quite a wide range. But regardless, 30% or 80%, that's still a significant amount of pregnant people. The reason why is when we think about the esophagus, there's a sphincter called the esophageal sphincter. It is part of its mechanism is hormonally mediated in that it requires certain levels of hormones to do its job. And so when you have these changes, that sphincter kind of relaxes and that allows acid to come up into the esophagus and then into the throat and mouth, and it's quite uncomfortable. Another cool fact about GI related changes is that salivation increases. And from an evolutionary perspective, we want that salivation to increase because we want you to be eating, we want you to be drinking, because your body needs nutrients to support a viable fetus and pregnancy. Urinary changes. As our bodies change in pregnancy, because of the physical space that the uterus and baby requires, and then also because of hormonal changes, our kidneys actually elongate by 1 centimeter, which is not something to be messed with in our bodies. 1 centimeter, even though it sounds small, that's a big deal for kidneys. And so when we talk about what, that implies or what, consequences can be because of that, that can change our resiliency towards fighting off upper urinary tract infections or even kidney infections, because there's just more room for things to get caught and stuck in. And so again, something to be mindful of as you progress through your pregnancy, and then us as physical therapists to be screening for too. Usually, well, I shouldn't say usually, commonly, patients may complain that their urinary frequency, so the amount of times that they urinate in a day, will increase. And this can be due to changes in glomerular filtration rates. So in the kidneys, there's all these little tubules that filter the water through, and the rate is basically the rate at which things are filtered. And so that filtration rate can actually increase by 40 to 50% due to an increase in renal plasma flow, renal meaning kidney, and looping back to when we were talking about cardiac changes, we were talking about the increases in plasma levels. So we've got arteries and veins that go to the kidneys too, and so that plasma flow will increase by 60 to 80%. So your body's physically processing more than it was prior to pregnancy. And so when you have more to process, you've got more particles in your urine. You have greater volume being excreted, number one, but then also two, if you have greater volume of particles in the urine, that can actually kind of irritate or tickle the lining of the bladder, which makes you feel like you have to go more often than you might have in the past. This increase in filtration rate delivers an overwhelming glucose load to the renal tubules. So this is basically a fancy way of saying the same thing I just said about those particles that can kind of be irritating to the lining of the bladder, but again, just more to process. And so this can also be a really great indicator of um, gestational diabetes. So when you are urinating, in general, pregnant people might smell their urine and it smells a little sweet. That would be something to speak with your doctor about because it may warrant further testing. There is some sweetness to the urine that is considered within kind of normal limits. But again, this is not something to be messed with and could be a sign of gestational diabetes, which is something that we want to treat appropriately as quickly as possible. And so, again, make sure that you are paying attention to that. Additionally, the bladder itself is displaced upward and kind of flattened by the uterus, simply because that uterus has to expand to accommodate a growing baby. And so, what does that mean for urination? Well, it has consequences. So, the detrusor muscle is the muscle of the bladder itself. This is not a muscle that we can consciously control. That muscle hypertrophies, meaning it gets thicker because we have changes in estrogen levels. However, because we have increased progesterone levels as well, it decreases the overall tone, um, which in turn increases its capacity. But again, because it's flattened, there's not as much overall room. So the body's really trying to accommodate it, but sometimes it can't accommodate sufficiently. And as I mentioned before, this can increase your risk for a UTI. So making sure that you're having really good vulvar hygiene is so important. Metabolic changes. So in early pregnancy, the body is in an anabolic state. Anabolic state means that we are building and repairing. So your body's going to lay down more fat cells. We're going to increase insulin sensitivity. And the reason why is we have to store nutrients and energy to meet the demands of a fetus and to accommodate the pregnant body's need for energy in later gestation and also for lactation. We're preparing for this postpartum time, right? In late pregnancy, we transition to a catabolic state, which is when you're breaking down large molecules into usable energy. So you're going to have decreased insulin sensitivity, increased resistance. You're going to have increased glucose and free fatty acid availability for fetal growth. So we're storing. And then as the baby's growing rapidly, we have to accommodate that. So our body's going to start to break down some of those storage places to feed the baby. Average weight increase during pregnancy is about 20 to 25%. and that is what we kind of expect and what we consider to be normal. And again, anything outside of that is something that we want to be communicating with birth workers about. Um, I do have a scale in my office. I don't know if all pelvic floor PTs do, but if I'm noticing something that feels off in regards to their weight, or the patient is expressing to me that they're a bit concerned, that's a quick, easy way to say, "Oh, yeah, it looks like you have, maybe lost too much weight or maybe gained too much weight." And we want to make sure that this pregnancy continues to be healthy. So let's communicate with your birth workers about that. And this part, we transition into my favorite piece, which is more of the bread and butter of physical therapy, as I like to say, is the musculoskeletal changes. So what's happening to your skeletal system, your muscles, your ligaments, your tendons. This is the fun stuff. So the physical rib cage starts to widen. So when you see there, it says subcostal angle, that's the angle. If you think of your xiphoid process, which is at the end here, and then there's an angle kind of downwards, that angle starts to widen. The costovertebral joints, quote unquote, open. So that's where those ribs intersect with the spine. And then you see those ribs kind of flare out laterally. Okay, so often people may complain of rib pain during pregnancy, and this is quite uncomfortable, but that's because physically things are opening and expanding to, again, accommodate this growing uterus and fetus. The SI joint, SI stands for sacroiliac joint. That's where the hips meet basically the lowest part of the back there. What we know is that movements in this joint increase to allow greater rotation and increase that pelvic diameter in preparation for birth. So the hips can articulate with the spine here by either rotating forwards, backwards. They can flare like this or like this. And the amount of movement I'm showing is a very significant over exaggeration, but just for the sake of this lecture to show you just exactly how it can change and articulate. Most slash many practitioners have a not so great habit of saying, "Oh, your SI joint is unstable," or "You have instability in your SI joint." And what we're finding is that's actually kind of a misnomer. That joint is very stable. It's a very rigid, robust, secure joint. And it's meant to be like that because it's at your root. It provides a lot of stability for your core and to keep you upright. And so what I have found in the past is that when practitioners have used that, it instills a sense of fear in the patient. They're worried that it might collapse or rotate, so significantly beyond the point of repair. And that is just not true. This joint is very stable. It can be a source of pain. It often is a source of pain or a source of dysfunction, but it is a stable joint. Moving on to the pubic symphysis, that is right in the front there, below the belly button, just above the clitoris and the vulva, where those two kind of hip bones come to meet in the front. And the symphysis is that joint. There's some connective tissue there. And so in a non-pregnant person, the amount of separation that is considered within normal limits between those two bones is 4 to 5 millimeters. During pregnancy, this can increase by an additional 2 to 3 millimeters. Some people that results in pain or dysfunction, some people it does not. Um, 24% of pregnant people have a gap greater than 9 millimeters. Again, the physical distance between the two does not necessarily correlate with increase or any symptoms by that means. Um, and so, again, looping back to when I was talking about the SI joint, sometimes I'll check people's SI joints, and because they're having pain there, and their alignment is perfectly normal. And then other people, I'll check their SI joints, and even in the absence of pain, and they're way out of alignment. And so again, the the objective fact or presentation of something like this does not always mean that you're going to have a symptom associated with that. Moving on to our coccyx, which is the tailbone. Um, when people complain of pain here, this can either be due to postural changes, which I will get to in the upcoming slides, or because of ligamentous changes. All of a sudden, this coccyx bone is exposed to a big increase in intrapelvic pressure. For most people, that coccyx bone, if this is the front of your body and this is the back of your body, that coccyx bone is oriented slightly forward. If you have a history of falls or coccyx pain, your coccyx bone may be more forward than is what what we would consider normal is. And so when you have this huge change in intra-abdominal pressure from a growing baby, plus you're constipated, which increases pressure as well, right? That can put a lot of pressure on your tailbone. And so that is just one or two reasons why someone may have tailbone pain during pregnancy. Changes to linea alba. So linea alba is the connective tissue that connects our six-pack together, which is really an eight-pack. But this is the line that runs right through the belly button all the way down to those pubic bones that we were talking about before. And so as our belly expands, right, we have to accommodate that somehow. And really because the body's going so rapidly, we either start to lay down more tissue along the linea alba, or it starts to thin and elongate. I really don't like to use the word stretch because I feel like that's not a very accurate description of what's going on. That implies that we can, I don't know, it just feels like a misnomer. I'll think about why I don't like it as much, but that kind of elongation or adding down of more cells along that, it's actually a strong piece of connective tissue. Again, people often are made to feel like their pregnant bodies are so profoundly weak or incapable of supporting themselves, and that is just not true. However, because this linea alba starts to change, what we do find is that it does impair load transfer and can cause instability in vertical loading tasks. So that really is a fancy way of saying if you do not have sufficient deep core and superficial core motor control, which is your ability to coordinate all those muscles exactly when you need them to, and you lack awareness of those muscles, if you go to lift a laundry basket, for example, those muscles inherently will have a more challenging time of bracing for that activity as opposed to somebody who is not exhibiting changes in their linea alba. And so this is a really crucial piece of where physical therapy can be really beneficial, even in the absence of symptoms, because this is exactly what we are trained to teach people to do, is how to coordinate these muscles to get the result that you require. When we think about nerves and neural tissue during pregnancy, um, commonly people will experience numbness or tingling, stabbing, shooting, burning pains in various parts of that pelvic girdle. And often what is the cause of this is changes in your skeletal system and posturing. And so inherently you're going to start to put more pressure on some of the nerves, and you will find that nerves do not tolerate change in homeostasis. Homeostasis is basically a scientific term for status quo. It likes a certain amount of blood, it likes a certain amount of oxygen, it likes a certain amount of space to move, and any kind of interference with that, it's going to let you know. So nerves that we as physical therapists assess for are ilioinguinal nerves, iliohypogastric nerves, lateral, femoral, cutaneous nerves, and femoral nerves. These exit laterally from the psoas muscle, which is a pretty popular muscle these days. And the psoas is a deep hip flexor and stabilizer to the spine. And so again, as that expanding belly, really the root of everything, right? It starts to put pressure on these things. But again, the changes in your posture, which generally results in that pelvis kind of tipping forward and you get an extra arch in your low back, that changes the mechanics of how that psoas works throughout your daily life. And so if those muscles are becoming shortened, which happens in an anterior pelvic tilt, or are chronically lengthened even, again, that changes the pressure on those nerves and can make it really irritating. Another one that we look at is the genitofemoral nerve. This goes through the belly of the psoas. Obturator nerve exits medially, which means towards the middle, through the obturator foramen, which is a bony structure in the pelvis. And then the sciatic nerve, this is probably one that most of you will have heard about. Sciatic nerve is responsible for basically the back of our leg, bottom of our feet, and our toes. And it passes through the piriformis muscle. Through or underneath the piriformis muscle. I will speak later about the piriformis muscle, but a quick note on that. Again, if that piriformis muscle is in a chronically shortened position, which means tight, or is in a chronically lengthened position, both of those positions are going to put more pressure on that sciatic nerve, which may or may not cause symptoms down the back of the leg. The round and broad ligaments are ligaments that are more internal in our abdomen. So the broad ligament passes from the side of the uterus up the lateral wall of the pelvis and is continuous with the peritoneum. This is a ligament that is less talked about, I would say, but can be a source of pain and discomfort, and is often misconstrued, or maybe I should say like misdiagnosed, or confused with the round ligament. So round ligament pain is quite commonly discussed in the pregnancy world, but again, it could also be or is just the broad ligament. So the round ligament starts on the anterior surface of the uterus, which is the front of the uterus. It goes up through the inguinal canal, which, if kind of think about that groin line where the hip creases are. It actually inserts into the labia majora. Ah, so cool how connected everything is, right? When we say round ligament pain, this often will cause sharp pain in the lower quadrant. So that would be like the lower parts of the abdomen there, but can also be a source of labial pain too. So now I would like to discuss postural changes. Postural changes are basically how we sit, how we stand, those kind of static positions. So again, going back to that growing belly, our center of mass is translated forward, right? So as our body builds more tissue out this way, our mass is going to translate forward with that growing belly. This can cause an increase in lumbar lordosis, which is that arched low back, by 32 to 50 degrees, which is significant. For somebody who measures lumbar range of motion, that is a big leap. Again, may or may not cause dysfunction. The mere presence of these things does not always equate to a symptom. But that's a big deal. That's a big change in skeletal structure. Our base of support is going to widen. So as our center of mass translates forward, one of the ways that we accommodate is by widening our feet to feel more stable. Our center of gravity is going to translate posteriorly into our heels. So as the belly comes out forward, and again, we're trying to accommodate, our weight starts to shift into our heels. So some people may experience pain in their heels as well. Some of that may be like a calcaneal fat pad syndrome, simply because of the pressure. Often gets misdiagnosed as plantar fasciitis, which is a whole other lecture and a completely different set of physical therapy interventions, but it is common to have changes there too. We're going to have an increase in anterior to posterior sway, so that's front to back, especially when we eliminate vision. So for example, if you were to stand somewhere with your eyes closed, our nervous system is going to sway forward and back. And that's because we're trying to find that center of mass. We've taken away one element of balance. We have multiple elements of balance. One component is vision. So when you take that away, naturally, we're going to have a little sway back and forth. But because of the changes to our musculoskeletal system, and then consequently to the mechanicoreceptors and proprioreceptors, which are the nerves in our ankles, our knees, and our hips that tell our brain where our body is in space, because of those changes, when you stand with your eyes closed, you're going to sway much more forward to back than you would in the absence of pregnancy. So this has huge implications for why we should be working with pregnant people on balance strategies. So hip strategy and ankle strategy, if you remember from neurological physical therapy coursework, are the inherent neurological systems that we have to prevent us from falling. So for example, if you are kind of lose your balance, one of the ways that you might catch it is by flexing your trunk at your hips to, again, augment that sudden change in center of mass or center of gravity. Same thing can happen at the ankles. And this is why working on these things can be really helpful for preventing falls during pregnancy, which is a problem and we want to avoid at all costs. In general, I would say that when we are working with people who are pregnant, we should be performing exercises with a larger base of support. So encouraging people to widen their feet, not to say that you can't train with a narrow base of support in a controlled, safe, spotted environment. But when you're doing exercises at home in an environment where somebody's not watching you or you're by yourself, I would really encourage people to just widen their base of support for the sake of safety. When we think about what is optimal posturing from a pelvic standpoint, we want that pelvis to be neutral or in a slight anterior pelvic tilt. So if you think about, you can see me standing up here from the side, this would be an excessive over-exaggeration of an anterior pelvic tilt. That's that 35 to 50 degree, or I'm sorry, 32 to 50 degree change in the lumbar lordosis that happens during pregnancy. So a neutral pelvis is one where you have a slight arch here, a slight anterior pelvic tilt, or just even less so. That's about probably perfectly neutral. We also don't want to have it over tucked. That can also lead to issues. So anything with a very slight arch here where you have good engagement of these muscles, but you're not just kind of, what I like to say, hanging out on your ligaments or hanging out on your bones. We want some kind of muscle activation there. Again, when we do that over tucking, so kind of rotating the butt underwards, or over exaggeration forward, your glutes, your erector spinae, which are the muscles that go alongside your spine, the rhomboid muscles, which are up here between your shoulder blades, and the obliques, which are on the sides of the muscles, get hugely and wildly overactive. When we have that lack of balance between musculature, the likelihood of having symptoms, whether it be leakage or urinary urgency frequency, pelvic floor muscle pain, pain in your glutes, pain in your back, pain in your upper back here, all of that likelihood of having that increases. And so again, working with a physical therapist who is trained to work with the pregnant population is going to teach you how to be mindful of posture, work on various stretches, exercises, motor control activities to augment these inherent changes that are happening as your body is preparing for birth. In people who have PGP, which stands for pelvic girdle pain, that's pain in the SI region, the hips, the pelvic floor, anywhere in that kind of circumference, especially, we want to make sure that from an exercise perspective, we're reducing opportunities where you have asymmetric positions. And the reason why is because the joint mechanics and faulty motor control, you just increase opportunities for that to happen. So when we talk about asymmetric positions, you can think of like a static lunge, for example. For people who have pelvic girdle pain, likely, not always, and this is where specifics comes in, and having a really good thorough examination from a physical therapist is so important. But likely that kind of positioning will feel more uncomfortable. And again, that's because of the shifting that's happening there. Gait changes. So this is changes in your walking style. So when I analyze gait walking patterns, I usually start with one joint. So I'll record somebody walking, and the first thing I'll look at is their feet. What are their feet doing? Then I'll watch it again. Okay, what are their ankles doing? Then I'll watch it again. Okay, what are their knees doing? And then what are their hips doing? What's their back? What's their thorax doing? What are their arms doing? And each one of those things, and then especially in combination of, can tell you so much about, from a motor control perspective, a strength perspective, what is going on in their body. So in looking at the feet of a pregnant person, and again, this is generally, so get into the specifics with your physical therapist. Generally, the feet tend to excessively pronate. So pronation, if you think of your feet right here, is kind of that rolling in. We should have pronation when we walk, especially in those first couple of moments when our feet are hitting the floor. That's how we absorb shock. We want that to happen. Pronation is not a bad thing. The problem is that when we can't control it and we can't get out of it. So if your foot stays pronated throughout the whole cycle of your walking, right? And so when we're pregnant, the tendency is towards excessive pronation, because now all of a sudden you have to absorb so much more shock from the ground reaction forces, because your center of mass is changing, your base of support is changing, and all of that. And the physical arch of your foot tends to flatten, again, to absorb shock and support your rapidly expanding belly. That tends to happen in weeks 12 to 34 of pregnancy. So what does that all mean? So that excessive pronation creates what we call a functional leg length discrepancy. So when we start to overpronate, it makes the leg function as if it were longer than the other leg. And so this causes a change in the pelvic tilt and may be a source of low back pain. This is, again, why it's so important to look at the whole person, not just where the symptom is, right? Because there are so many answers that can be found in other parts of the body too. These changes in how our foot is absorbing shock and functioning is often coincided with an increase in internal rotation of the femur and weakness in the hip abductors. And so when I say weakness, I don't always mean a true weakness, because I don't want to imply that when you're pregnant, all of a sudden your body becomes weak. However, if you don't have a sufficient baseline strength, or if you don't have the sufficient motor control for your brain to tap into that strength, it can present as a functional weakness. And so your femurs, which are your thigh bones here, tend to rotate inwards, and the knees kind of look like they start to collapse a little bit. And this puts a lot of pressure on the inside of the knee, puts a lot of pressure on that SI joint region, and causes this overstretching of the piriformis. That's what I was talking about when we were talking about the SI joint changes in the skeletal section of this lecture. Again, this is where physical therapy is so crucial in addressing strength training and motor control training. So often I will have patients stand in front of the mirror, or again, videotape them walking and have them watch it and ask them what they see. And most people will identify these issues immediately, and having that awareness can drive internal changes too. And just that little bit of awareness, or that little bit of attention to where their thighs are moving, how their knees are moving, how their ankles moving, can make a huge difference in somebody's symptoms. The other things that change during pregnancy in regards to walking is that you have what's called increased stance time, which is the time in which your leg is physically on the ground as it's moving behind you before you pick it up to do it again. So that means more time on the ground. The width between your feet increases by 15%. Your step length, which is foot to foot length, decreases because you're trying to keep from falling, right? And we want to keep our feet underneath us. The amount of time of when both feet are on the ground increases, which normally should be, depending on the speed of walking, should be pretty minimal. And walking speed tends to decrease as well. The interesting thing about these gait changes is that these changes can persist up to 8 months, sometimes more, into the postpartum period, even though you no longer have a pregnant belly. Ugh, mind blowing. Um, and so this can be so important um, when we think about postpartum rehab, because again, so many of the answers may lie solely here as in regards to somebody's function. In particular, I want to point out that the walking speed has particular implications for leaking with walking and running. So often, I will do a pelvic exam on someone who reports urinary leakage with walking or running postpartum, and their pelvic floor muscles are perfectly strong. They've got great endurance, they've got great fast twitch muscle fiber activation, but for some reason, they're leaking when they're running and walking, and often the answer or clue is in their walking speed. And so if you have them download a metronome to their phone and have them increase their cadence, bam, their leakage just goes away. And that's because you decrease the amount of time that the ground reaction force has to shimmy its way up to the pelvic floor and abdomen, and decreases the amount of intra-abdominal pressure. So again, treating the whole person and really looking at each component of their body can give you so many answers, and really can be, all of these things can be drivers of somebody's symptoms, not just physical pelvic floor muscle strength, which is why we so often emphasize it's not just about Kegels or pelvic floor contractions, right? Many people do not need to do them as much as they do, which is a whole other lecture. So all that to say, holy cow, so many changes. And I want to pause here for a moment to say all of these changes are so important and ultimately good, right? Because they result in, a healthy, viable pregnancy and fetus. And we want these changes to happen. It is important to know that these changes are happening because sometimes they can result in symptoms and dysfunction. And just because you're pregnant does not mean that you have to settle for that symptom or that kind of dysfunction. Often, pregnant people are made to believe that their symptom or dysfunction will just go away when they're suddenly not pregnant. But as you saw in that previous slide alone, these changes can persist well into the postpartum timeframe. And my counter argument always is, especially to birth workers, namely doctors, is that even if it were true that someone's pain or dysfunction might go away once they're suddenly not pregnant, why are we letting people suffer for 9 months when we know that increases in pain and dysfunction lead to greater rates of disability, greater levels of stress, all of which have very severe consequences for the success of labor and birth, and therefore get carried out into postpartum. And so when we talk about the necessity of physical therapy for all pregnant people, this is exactly why. I would now like to transition in briefly to talk about preparing for labor and birth. So, pelvic floor physical therapy or physical therapy for pregnant people um, really can kind of be three different columns, right? So, one is, preventing um, issues in the postpartum. Two would be addressing pain or dysfunction that arises during pregnancy. And then three would be preparing for labor and birth, a very important time. Now, I often compare labor and birth to a football game, not because I particularly enjoy football, but because it's an easy comparison for many people to understand. So if what happened to a man's quadricep, I'm sorry, if what happened to a pregnant person's pelvic floor if what happened to a pregnant person's pelvic floor during labor and birth happened to a man's quadricep during a football game, they would be in physical therapy for up to a year. And that's even, considering a football player who's gone through all sorts of training to prevent these things from happening, right? Yet pregnant people are left with nothing. And so um, there's so much that we can do to prepare our bodies for that intrapartum time frame, but will also carry over to the postpartum time frame. And again, this is just a brief lecture. There's so much nuance and context to a lot of this, but this is will hopefully give you a sufficient idea of what we're talking about. So first, we talk about the breath. So when we watch people give birth on television and movies, and then consequently in hospital settings, most people are coached to um, take a big inhale, hold your breath, and then push like you are pushing out poop, which is actually not the correct way to push out poop. um, but that's called a Valsalva breathing style. And what actually happens during that Valsalva breathing style is that the pelvic floor actually tightens up into the pelvis. And so trying to move a baby through a tight and shortened uh, series of muscles, three layers of muscles that are like that, is really challenging and can lead to all sorts of things like pain, delayed birth, tearing, um, all sorts of stuff. Coccyx issues, coccyx bone fractures, lots of things. What the American College of um, Obstetrics and Gynecology has finally said, yay, is that um, people should actually be coached to breathe in a way that feels good to them. And that's actually the most effective. The issue is that how do you know what kind of breathing style is right for you? um, and if you haven't practiced, or if you aren't aware of the different ways of breathing, you're not going to have tools in your toolbox to whip out in the moment and say, oh, this doesn't feel right, I'm going to switch to another breathing style, right? And so you want to have that kind of what we call motor planning. You want to have options in the moment. And so again, this is where physical therapy can be so effective. Um, this continues to explain everything that I just said, but one of the ways that we can teach people to breathe better during the second stage of labor, which is the active pushing phase, um, is that we want to breathe with controlled lengthening of the pelvic floor muscles. So when we think about that, what does that mean? Breathing with an open glottis, which is like a kind of exhale. The vulva and vaginal canal mirrors what we do with our glottis here. Um, that can mean breathing, or it can be vocalizing, as I just demonstrated, or we can use mantras. So finding a phrase that feels good to you, like, I can do it, I can do it. That kind of verbiage opens the glottis here. And so practicing that can be a really good way to make sure that you are able to tap into multiple different options if you need them. Positioning. This is a big topic and can be controversial in that, specifically in a hospital setting with a medically managed birth from an obstetrician. Um, Many of them are not always open to alternative birthing positions other than what is called the dorsal lithotomy, which is what you typically see in movies where you're kind of laying on your back and somebody's whipping your legs back up to your head. That is not to say that this is a terrible position for all people. It actually is the right position for many people. Um, but it's also the wrong position for many people. And if you have hip issues, for example, like a labral tear, this position isn't going to be super great because your hip is being pushed into end range hip flexion and can cause pain or maybe further damage to the labrum. And so having that context and conversation with your providers is super key. If you are having trouble communicating with your provider, working with somebody like a doula can be so helpful, or working with your physical therapist. We are more than capable of facilitating interprofessional communication, either in the form of a letter, email, a phone call, to explain why this kind of birthing position may not be best for you. And so, if everybody's on the same page, um, that is going to improve your successes. So this dorsal lithotomy position, let's dive into it a little bit deeper. What we know in the research is that generally it increases the need for perineal sutures, which means that the rates of tearing of the perineum muscle, which is that muscle between the vaginal opening and the anus, um, the rates of tearing in that muscle are a little bit higher, and so it increases your need for stitches there. It is associated with more severe pain. It does have a higher episiotomy rate. Episiotomies are a little bit more old school now. That's when the birth worker will actually use a scalpel to cut through the muscle. Usually it's in an emergency when the baby's quote unquote stuck in the vaginal canal. When you think about this position, the orientation of the vaginal canal is actually upwards, so you're pushing uphill. So the chances that the baby, quote unquote, gets stuck in the vaginal canal are actually kind of higher too. And so, therefore, birth workers are kind of forced to use things like an episiotomy or an instrument assisted delivery, which would mean forceps or a vacuum to get the baby out. This position also has a higher risk of extremity nerve injuries due to prolonged compression at end ranges of motion. So, if you remember back a couple slides before when I was talking about some of the nerves that change or may be involved in somebody's pain during pregnancy, those are all the same ones that can be compressed depending on which position you're in for a prolonged period of time. So I always recommend, like, if you are in this position specifically, but others as well, you need to communicate that your body needs breaks. So in an active contraction, yes, have those legs up there, work on your breathing and your pushing, but when the contraction is done, your legs go back into the stirrups, or back down out of somebody's hands, because you do not want those nerves to be compressed. All too often, I see um, the only time a physical therapist is referred to the labor and delivery floor is when one of those nerves gets compressed and somebody has trouble walking after birth, and they need gait training, which is walking training with a walker. And that is something that is preventable. So again, making sure everybody's on the same page as far as like, listen, my body needs rests in between contractions. If you need to, write it down, and so that you can share that with all of the nursing staff and birth workers too. This position also may prohibit sacral nutation, which is required for the opening of the outlet. So that sacrum is the triangle bone at the end of the spine. In order to increase the pelvic outlet, which is the base of the pelvis, it has to, so if we're looking from the side, it has to move this way to make more space. So if you're on a bed, imagine a bed right here, it can prohibit that movement, and therefore keep it in a more narrow place and again allow for the slowing of labor and birth. When we look at the side lying position in the research, so this would be laying on your side, either with a peanut pillow between your knees, your leg up. Those hospital beds are really cool, and you can move all those different components. So your leg can be up on one of the components of the bed, or if somebody's holding your leg up for you. This is actually the position that is least likely to cause perineal tearing. 66% of people who gave um, birth in this position had a completely intact perineum, which is that's a great percentage. Um, this position avoids compression of all joints. So again, if you're somebody who's got a labral tear in their hip or a known um, lumbar disc herniation, or you've got knee issues, this is a really gentle position that's going to put you in the least amount of pressure. This position is really helpful for people who are premiparous or have larger newborns, and may actually help to kind of slow a precipitous labor. So precipitous labor is one that's happening like way too quickly. Quadruped is on your hands and knees. There's much less need for perineal suturing as opposed to the dorsal lithotomy position. Um, and 61% of people who gave birth in this position had a completely intact perineum. Woohoo! Squatting. Squatting is a great position. It is one of the most, from an evolutionary perspective, when you look at the evolution of birthing practices, is one of the most like ancestral and deeply rooted in birthing practices. It may help to shorten second stage of labor, so it gets things moving a little bit quicker. It may reduce the need for oxytocin to stimulate birth, so reducing the amount of medical intervention. People who gave birth in this position had fewer episiotomies and less severe perineal lacerations. Again, a really important note is you want to rest in other positions between contractions, because squatting for 20-30 minutes, that's a lot on the knees and ankles. So making sure that you have lots of resources and people nearby so that you can quickly move in and out of those positions as needed. There is some research that shows that squatting can cause perineal tearing. Often, if that is the case, it's because things are moving a bit too quickly, and so. But again, when we look at the research, the grading that is given to the perineal tearing is much less severe. So perineal tearing is graded in 1, 2, 3, and 4. So that would mean that we're seeing more of the 1s and 2s and less of the 3s and 4s in this position. So, what is the moral of this story? When we think about the breathing, when we think about positions, um, you know, working with a pelvic floor physical therapist, we can say, okay, I want to see you do this particular style of breathing in this particular position. Oh, that doesn't work. Okay, let's try this other position. Oh, that's really successful. You do a good job there. Okay, I think this is a great position for you. This is maybe what we should go for. But ultimately, what it's about is like in the moment, you may feel really uncomfortable in that position for whatever reason. But having been working with a physical therapist and having tried multiple positions, you're going to have that in your movement vocabulary. So you're going to say, "Oh, I remember when my PT Molly, she said, if it doesn't work in this position, let's try another one." You're going to have that within your body so that you can be successful in the moment. You would never show up to a football game, going back to that analogy, without having had any kind of training. You would never show up to a marathon without having any kind of training. And it doesn't mean you have to show up completely prepared, but you got to show up with a a wide array of movement vocabulary, a wide array of breathing styles. You want to know how to get in better positions so that you can reduce other sources of pain that may be causing you stress or causing labor dystocia, which is the stalling of labor. You just want to have that within you. And so, again, as I reflect on kind of the marriage, for lack of a better word, of physical therapy and the pregnant population, um, we really want to be a part of the treatment plan and a part of the success for pregnant people, even in the absence of pain or dysfunction. If you come in for one or two visits, you can learn a lot and we can cover a lot of ground. And there may be things that we pick up on that a doctor, for example, may not up on because they're only allowed to have 10-15 minutes with you. And so, if we can create really the team approach between the nurses, the doctors, midwives, doulas, physical therapists, nutritionists, GI specialists, you name it, we really can set people up for success. And I hope that this presentation really shows the value that physical therapists bring to the table in regards to working with pregnant people. And here are all of my references. Thank you so, so much for listening, and stay tuned for further lectures on physical therapy and our role in postpartum recovery. Have a great day.